So, topic for this today's IC is management of astigmatism in keratoconus. We all know the basics of keratoconus, much has been talked about. Earlier, it would be called as non-inflammatory disease, but now we have been able to identify the inflammatory markers within the cornea. I always refer this to as inflammatory disease. Keratoconus is a disease where the cornea thinning happens, and the end result of which is it starts developing a astigmatism. It starts as a skewing of the axis, it progresses to obliquity, it enlarges, it becomes irregular. Keratoconus management is all about managing the regular to irregular astigmatism or oblique to irregular astigmatism. Majority of the times, these days, because of the better diagnostics, especially in the tertiary care centers, we are able to diagnose much and more number of keratoconus. But in primary or secondary care centers, the clues which are given by the keratoconus patients are frequent change of glasses, rubbing and unhappy with their glasses. And in the tertiary care centers, LASIK rejects are always suspected for keratoconus. And whenever we talk of keratoconus, there are 2 to 3 things which comes into my mind. Form first day, keratoconus suspect, and subclinical keratoconus. All these 3 things, they look similar, but there is a difference in topography in each and everything. We need to understand the minute difference between these 3 things because these are the very, very, very early stages of keratoconus. FFKC means it could be the fellow eye of a clinically manifested contralateral keratoconus eye. It doesn't have any clinical signs. Topography signs may not be there except for minimal skewing. In a keratoconus suspect, there are so many definitions which are given by multiple scientists. According to Rabinowitz, there could be no slit lamp findings, there could be no scissoring, and we can see a skewing with asymmetric bow tie pattern. And for subclinical keratoconus, they have given a criteria for major and minor criteria where all the indices are altered. But clinically on slit lamp, you will not find any signs. Added to this, when we assess for the biomechanics, the corneal resistance and the hysteresis is significantly reduced in all subset of early keratoconus when compared to the normal keratoconus patients. And Dr. Rohit was mentioning in his talk that vertical coma and horizontal coma is one of the important aberrations that abnormally gets elevated in a very early keratoconus patients. That has to be kept in the mind in a LASIK vision. So these are the things which everyone is aware, which should be kept on the mind whenever we diagnose a keratoconus. And we should also pay importance while managing the astigmatism to the risk factors which add up to the progression of the keratoconus. This is the simple chart which simply explains how we are going to manage the astigmatism in keratoconus. The protocol has been completely changed after the procedure of C3R has been adopted in our practice. If we document a clear-cut case of progression with associated risk factors on a first shot, we are going with a C3R and we are going to rehabilitate the patient with spectacles or contact lenses, which I will be described in the next slide. If the patient is of low or moderate risk, if it seems to be non-progressive in nature, we can start observing by rehabilitating him with contact lens or spectacles. If it is progressive, if the patient is contact lens tolerant, we can do C3R and advise him to go with contact lenses. If he is intolerant, we have procedures where the LASIK is combined with C3R and we have Intacs followed by ICL, which I will be explaining. This is the important chart that has to be kept on our mind. This explains the complete management of keratoconus. There are invasive and non-invasive procedures. Coming on to the glasses. Usually glasses are well tolerated until power of minus 2.5. If it is beyond 2.5, if the patient visual acuity is not improving beyond 6/9, we may have to shift him for contact lenses. And the contact lenses have major advances these days. We have soft torics, we have RGPs, and we have scleral lenses. Soft lenses is not a best choice if the cylindrical power is more than 2.5. The problem with soft lenses is they rotate with the blink. This itself will cause a fluctuating vision. And these soft lenses, they are very more prone to dry out. And it's ideal only for early keratoconus patients. RGP lenses are optically superior when compared to the soft. They are bigger than, they are very smaller than the soft contact lenses, and they are better for higher degrees of astigmatism. The advantage, because of its hardness, they get aligned along the curvature to provide a superior and stable vision. Since they are very small, the repeated interaction with the lid margins causes discomfort and patient may not accept it easily. To overcome this, scleral lenses has been developed. These are very bigger lenses than RGP and slightly bigger than the soft lenses. Comfort levels are very good and they usually do not dry out. The only side effect is they are expensive when compared to other two lenses. This is how the bad fitting appears, and if it's a good fit, it needs to appear like this. C3R entirely changed the scenario. As I told you, if we have documented a progression, if there's associated factors, we need to go with the C3R, either the routine protocol or accelerated C3R. Both gives fantastic results. We know the principles, how it works. Solutions are available. Earlier when it was procedure started, we had riboflavin coming up with the Dextron, which is high molecular weight. We need to completely remove the epithelium. Now we started using 0.1 riboflavin, the HPMC, which can go through the intact epithelium, where we can do it on epithelium on procedures. And the majority of these C3R procedures, the effectivity remains the same. Once it is stabilized, I prefer to do a PRT based on the Athens protocol. People who have access to topo-guided treatment, they do combine collagen cross-linking with topo-guided examer procedure. Since we at Lotus, we have topo-guided for any early astigmatisms which are less than -2, I prefer to do a wavefront guided procedure. But to do this, Athens has given a protocol that we should not ablate more than 50 microns. Minimal pre-op thickness of the patient should be more than 450. Do not make it less than 380. And since there is a tendency of haze because of excimer and the C3R procedure, do apply mitomycin 0.02% for 20 seconds. Or if you have an option for epical removal with excimer, you can go with options of PTK. So lasers in keratoconus is an option. Risk of ectasia is not documented. We have done around 40 to 50 patients. Patients are doing good. I was just worried about the haze, so we do keep them on fluorometholone for 3 to 4 months. Here, emotropy is never a goal. It is just to reduce the power of astigmatism. This is the most important thing that is widely followed. Once the astigmatism is well stabilized with the C3R, we can go and opt for ICL. Again, the toric ICL is to reduce the glass dependency, not for complete glass-free vision. Intacs has been an option in the past. We stopped doing these procedures way back in 2014-15, but here you need to have a minimal thickness of 450 microns in the 6 mm zone to stabilize the cornea. The channels can be either made manually or through the femto-assisted procedure. So if the keratoconus is very advanced, the final option is PKP or dye. And finally, while managing the astigmatism, do not forget to assess the progression at all stages. How to define this progression? You should be able to document an increase in 0.5 diopters in 2 or more keratometric values in the steep meridian between 2 sagittal maps. If there is a significant corneal reduction by 10% and more at the thinnest point based on your pentacam readings, or if you clinically see a significant jump in objective values of astigmatism and refraction, and watch out for the aggressive factors such as eye rubbing, VKC, and other. Thank you.